Everyone. It is my pleasure and privilege to warmly welcome all our esteemed, respected dignitaries, faculty members, and dear delegates and participants to today's session of the ICP Advanced Clinical Certification course on tropical diseases, fifth module. This academic initiative by the Indian College of Physicians continues to bring together practical, clinically relevant insights for physicians across the country. Tropical infections often present with overlapping clinical features, posing significant diagnostic and therapeutic challenges. A clear understanding of these diseases is essential for early recognition and better patient outcomes. We are fortunate to have with us an excellent academic team for today's session. I welcome our respected patron and editor-in-chief of API Textbook of Medicine, Dr. K.K. Parikh sir, our Honorable Dean, Dr. Girish Mathur sir, Course Director, Senior Professor Dr. Anupam Prakash sir, today's faculty and Professor in Medicine, LHMC, Dr. Rupali Malik madam, and all our esteemed delegates. With this, let us move forward and begin today's our academic journey. I now request our esteemed Dean, Dr. Girish Mathur sir, a guiding force behind the academic vision of ICP, to address the gathering and share his valuable insights. Sir.
Good afternoon, friends. Honorable Dr. K.K. Parikh sir, Chief Editor, API Textbook of Medicine, our source of inspiration, guide, patron, mentor, Dr. Ashutosh, Dr. Anupam Prakash, Course Director and Member Governing Body API, Dr. Rupali Malik, distinguished speaker of this afternoon. It gives me great pleasure to welcome you all on the fifth module of the ICP Advanced Clinical Certification course on tropical diseases. This academic initiative reflects the unwavering commitment of Indian College of Physicians to advancing clinical excellence and strengthening evidence-based practice among physicians. The current module focuses on an important and often under-recognized spectrum of infections, Leptospirosis, Rickettsial, and other zoonotic diseases. These conditions continue to pose significant diagnostic and therapeutic challenges, particularly in tropical regions like ours, where overlapping clinical presentations and limited early recognition can impact patient outcomes. We are privileged to have Rupali Malik as the esteemed speaker for this session, who will share her expertise and clinical insights into the timely diagnosis and management of these infections. Her experience will undoubtedly help participants sharpen their clinical knowledge and improve patient care. I would also like to acknowledge and appreciate the efforts of the course director, Dr. Anupam Prakash, whose vision and leadership continue to make this certificate course a highly valuable academic platform. So I welcome you all this afternoon. Over to Dr. Ashutosh.
Thank you, sir, for your kind words. I would now like to invite our respected patron, Dr. K.K. Parikh sir, a stalwart in Indian physician fraternity, to bless this session with his thoughts. Sir, please unmute. Yeah.
Ashutosh.
Yes, sir.
Thank you, dear. It's really a great pleasure and an honor for me to be a part of this very important and a great academic vision of Dr. Girish Mathur, that I'm part of this very important ICP Advanced Clinical Certificate course program. This is today we are witnessing fifth module of these certificate courses, and this is a very important topic which is going to be, we are going to discuss leptospirosis, rickettsial, and zoonotic infections by our very learned speaker, Dr. Professor Rupali Malik, who needs no introduction to all of us. I also take pleasure in welcoming our Dean, Dr. Girish Mathur, Dr. Ashutosh Chaturvedi, Dr. Tansukh Chaudhary, Dr. Krishna Mohan. I can see all delegates. So all delegates who are attending today's program and making it a great success. I hope with today's deliberations of leptospirosis, rickettsial, and zoonotic infections will be much more wise for tackling such infections in our OPD and indoor also. So it's a great vision of our Dean, Dr. Girish Mathur, that we are almost every month we have got 2 or 3 programs continuous. So it's really a great dissemination of knowledge which is required for all of us. So thank you. Thank you very much.
Thank you for your blessings and kind words, sir. It is very heartening to see a lot of delegates joining every Sunday afternoon for these courses all over the country. API members like Dr. Geeta Arora madam, Dr. Tansukh sir, Dr. Krishna Mohan Gupta sir, Dr. Deepak Upadhyay sir, Dr. R.P. Parikh sir, and many more. So now I take the opportunity to acknowledge and welcome our course director, Dr. Anupam Prakash sir, whose leadership continue to drive this course with remarkable academic rigor and relevance. We are equally privileged to have our esteemed speaker, Dr. Rupali Malik Madam, who will be sharing her expertise and practical insights on this important subject. I am confident that today's session will be highly enriching and thought-provoking for all of us. Now, I would like to invite our course director, Dr. Anupam Prakash sir, to kindly take over and set the stage for today's session. Thank you, sir.
Well, thank
I
you,
must
Dr.
also
Ashutosh.
congratulate Dr. Anupam Prakash for his great efforts in
Thank you so much, sir. And I am
modulating
deeply
these. Yes. Thank you, dear.
Thank you, Dr. Parikh sir. I am deeply obliged to Dr. Parikh sir and Dr. Girish Mathur, as well as President API Dr. Narsimlu. So Dr. Girish Mathur and Dr. Parikh have been the force behind this, and it is good that they have been able to give us an opportunity to talk on this important topic of tropical infections. And we have nearly now coming to the end of the course module. So another couple of sessions remaining, and we have talked of important topics like enteric fever, malaria, dengue, and the topics have been dealt with various seasoned speakers. And today also Dr. Rupali is from Vardhan Mahavir Medical College, Safdarjung Hospital, which is one of the largest hospitals in Delhi, and it caters to an immense patient load. So, in fact, recently AIMS Delhi has expanded, but otherwise Safdarjung caters to the downtrodden, poor patients, needy patients, and it has a very large rush. And Dr. Rupali Malik is there from Safdarjung. She has done her post graduation and graduation also from that place, and I am sure she has a wealth of experience, and she has been a continuous part of many of our academic activities. So I hand over the mic to Dr. Ashutosh. Shall I hand over directly, or you will be calling her out? So I hand it over to Dr. Rupali Malik. Dr. Rupali, please take over for today's session. Thank you so much. Thank you again, Dr. Parikh sir and Dr. Grish Mathur for the kind words.
Thank you.
A very good afternoon, all seniors. At the outset, I'm extremely thankful to our course director, Dr. Anupam sir, and all faculty members for giving me this opportunity today.
Good afternoon, ma'am. Myself Gautam. Now I'm going to mute all and I send a request to unmute yourself only.
Is my screen visible, Dr. Ashutosh?
No, ma'am, not yet. Kindly share. Kindly unmute yourself, ma'am.
Is the screen visible now?
Yes, ma'am.
So without much delay, I would now like to start. And the topic for today's discussion is leptospirosis, rickettsial infections, and these zoonotic infections. Now, why is it important for us as physicians to discuss this topic? Because all these conditions are important causes of acute, undifferentiated fever in tropical regions. And the early symptoms being non-specific would often lead to a delay in the diagnosis, and a careful history regarding travel, occupational exposures, animal exposures, or insect bites is essential. I would take you all through some examples which would make us all easy to understand what these infections are and how will they present. Okay, so the
Dr.
first
Rupali,
is,
can you put on slideshow mode? I think it is not yet on slideshow.
so it is on slideshow me.
Okay, then it is fine. It is visible. Please go ahead.
Okay. Okay, so the first case scenario is a 27-year-old male farmer, resident of rural area in eastern UP, presenting in post-monsoon season in the medical emergency with high-grade fever with chills for 7 days, associated with generalized body ache, myalgia, headache, and fatigue. He also has yellow discoloration of the eyes for past 3 days, along with decrease of the urine output, a maculopapular skin rash, though there is no eschar, no bleeding from any other site, or no history of diarrhea. On examination, he has fever, 102.5 degree Fahrenheit. Pulse rate is high. Blood pressure is 96/62. The respiratory rate is also high, 22 per minute, and saturation is 97% on room air. So on examination, he has icterus, mild dehydration. Per abdomen, there is tender hepatomegaly, and the tip of the spleen is also palpable. On examination of the chest, there are occasional bibasilar crepitations, though CNS examination reveals no meningeal signs and the patient is alert. So, in the setting of the today's lecture, what do you think the patient has? Would anyone like to give me an answer? Or the delegates cannot unmute themselves? Okay, so this is the classical maculopapular rash that was seen on the lower limbs of this patient.
Ma'am, excuse me, ma'am, sorry to interrupt you. Please put in, ma'am, full screen mode.
Full screen.
Not in full screen mode. Yeah. Make it slideshow. That above slideshow. Click on slideshow mode.
Yeah, slideshow beat happened.
Yes, there.
Just a second.
It is there, ma'am.
Is it now there? Slideshow?
Oh, right upside, ma'am. There is the tab slideshow. You can see that slideshow written.
Is it fine now?
Full screen.
Full screen he had.
I mean, enlarge it from there.
Is it okay now?
That's okay, ma'am. Fine.
Because it's like full screen on my screen. Okay. So moving on further. So with the setting of post-monsoon season, high-grade fever with jaundice and kidney involvement, decreased urine output, and a maculopapular rash, the most likely diagnosis is leptospirosis. So now what is leptospirosis? Now, it is a disease caused by the leptospira, and it has an incubation period of ranging from 2 to 20 days. The reservoir would shed the organism, the reservoir host would shed the organisms in the urine, and that is why the water will get contaminated. So either when you involve yourself in some sports involving water, or you do swimming, or any such exposure is there, or in the post-monsoon season, if you are a farmer, you're working in the paddy fields, you can get exposed to this organism. And after the incubation period, there's an acute phase followed by an immune phase, and finally the recovery phase. In the acute phase, the organism can be detected in the blood, it can be detected in the CSF, or as well as it can be detected in the urine of the patient. And in the acute phase, you have non-specific sign and symptoms. So in the initial first week, you have just fever, headaches, myalgias, etc. But when there's actually immune phase setting in, then is the organ system involvement seen. The most common organ system involvement seen is the hepatic involvement leading to jaundice. There can be renal involvement, renal failure. And what is being increasingly recognized these days is the pulmonary involvement, the pulmonary hemorrhages leading to cough, expectoration, and often hemoptysis. So this is what is seen in the immune phase, followed by the recovery phase, in which most of the patients would usually recover completely. Some patients may have some persistent kidney dysfunction, fatigues, and some other problems, which we would just discuss subsequently. So again, this graph shows you the same thing. So there's an acute phase, there's an immune phase, and a recovery phase. So in acute phase, again, non-specific symptoms where the leptospira can be isolated from the blood, CSF, and the urine samples. The antibodies would start rising in the convalescent stage or the immune phase. So the second phase would have the antibodies coming up. The cultures can also be seen. Cultures can also be done, and the initial phase you will have the organism in the blood culture. In the second phase, towards the second week, you can culture them from the CSF samples, and later on you can culture them from the urine samples. So it is in the urine where the organisms would persist and would lead to dissemination to other people around. And in the recovery phase or in the later phase, once the recovery has happened, some late complications can still be around, like uveitis, interstitial nephritis, etc. So in patients of severe leptospirosis, it is a rapidly progressive disease with a very high case fatality rate of around 1 to 50%. And the predictors of high mortality in patients of leptospirosis include age more than 40 years, altered mental status, acute renal failure, respiratory insufficiency, hypotension, and arrhythmia. So if a patient has all these features, the chances of mortality are much more. The classical presentation or the triad known as Wheel syndrome is the triad of hemorrhage, jaundice, and acute kidney injury. So in patients of leptospirosis, the patient would usually die because of septic shock with multi-organ failure or because of the bleeding complications, which can involve the lungs. The pulmonary hemorrhage can be there, or can involve GI tract in the form of melena, hemoptysis, or they could be bleeding from the urogenital tract in the form of hematuria, or they could be bleeding from the skin. So petechiae, ecchymosis, etc. could be there, or from the venipuncture sites, they could be bleeding. So in patients of severe leptospirosis, the fatality rates are really high. So it is important that we have a high index of suspicion and treat them timely. Now, this pulmonary hemorrhage or the pulmonary involvement was not a prominent symptom earlier, but nowadays there is increased incidence of presentation with the involvement of the lung, and cough, chest pain, respiratory distress, hemoptysis may often be the presenting complaint of these patients. It is not just jaundice or the renal failure, it could be the lung involvement, which could be the presenting feature. Jaundice is often seen, it can be profound, and is usually associated with enlarged and tender liver, as we had in our patient. Then acute kidney injury is again common. It can present several days after the illness, and it could either be non-oliguric or oliguric. And there are typical electrolyte abnormalities seen in these patients, like hypokalemia can be there, and even the loss of magnesium through the urine can be seen. Sometimes other complications can also be seen, like necrotizing pancreatitis, cholecystitis. There can be skeletal muscle involvement, rhabdomyolysis can be there, elevated creatinine and kinase levels could be there, and then there could be neurological manifestations like aseptic meningitis. And another important complication which can happen in these patients is the cardiac involvement, which can also lead to death. And rarely, hematological complications like hemolysis, the TTP, or HUS syndromes can be associated with infections like leptospirosis. Some patients would end up with long-term symptoms of severe leptospirosis, which include fatigue, myalgia, malaise, headache, which may persist for years. And in some patients, even uveitis, an autoimmune kind of uveitis, may persist for a long duration. So several years after leptospiral infection, the patient can still have manifestations of autoimmune uveitis. Now, to diagnose these patients, so there are some non-specific markers that you see, like leukocytosis are there with the left shift. There's elevation of markers of acute inflammation like CRP, ESR, thrombocytopenia is there, which is then leading to the all hemorrhagic complications. In severe patients, you can have signs suggestive of DIC or as well. In urine, you can have urinary sediments, including the pus cells. There could be RBCs, so leukocytes, erythrocytes. There could be cast, hyaline cast, granular cast, etc., which can all be indicative of the renal involvement. Mild proteinuria can also be there. And in severe patients of leptospirosis, frank renal failure and azotemia can be there. In mild, you can still have just mild proteinuria and some sediment, but in severe, there is frank renal failure with azotemia. Sometimes the patient can have non-oliguric hypokalemic renal insufficiency as well. The bilirubin levels are usually high. The rise in the aminotransferases and the alkaline phosphatase are usually moderate. The amylase levels are often elevated. And sometimes even there is evidence of necrotizing pancreatitis, though that is very rare, but still it could be there. Aseptic meningitis can be a feature in these patients, and the examination of CSF would reveal pleocytosis with polymorphonuclear cell predominance, with elevation of proteins. The CSF glucose is normal, and in patients of severe leptospirosis, there are classical radiological findings on the chest X-ray as well, which include the patchy bilateral alveolar patterns corresponding to scattered alveolar hemorrhage, and it is most likely to involve the lower lobes. Sometimes there could be pleural-based densities, which can again be indicative of the areas of hemorrhage, or there could be diffuse ground glass attenuations suggestive of ARDS. Now, for the specific diagnosis of the disease, you could either do a culture. The sensitivity is 5 to 50%, but the specificity is 100%. Then dark field microscopy could also help us in identifying this organism. Though again, the specificity is low, it can be confused with the protein fibers, and the sensitivity also requires a good number of bacteria around. The serological testing is what we usually depend upon. So it could either be the microscopic agglutination test, which could be utilized. They have good amount of sensitivity and specificity, or ELISAs can be utilized, or lateral flow assays can be done. And what is the best test that you can offer to your patient is the real-time PCRs. They have high sensitivity and specificity. So real-time PCRs and various samples like the blood, urine, and CSF are most helpful. Coming on to management of leptospira infection. So in patients with mild leptospirosis, you can give oral drugs like doxycycline, which is usually the drug of choice. If not, then you can give amoxicillin or ampicillin. In moderate to severe patients, you can give penicillin or the third generation cephalosporins like ceftriaxone or cefotaxime. Or you can give a loading dose of doxycycline, IV doxycycline in place of oral in patients with moderate to severe leptospirosis. Chemoprophylaxis can also be given in patients who have been exposed or who are going to travel to the endemic area. So doxycycline once a week can be considered, or azithromycin once or twice a week can be considered for chemoprophylaxis of the leptospira infection. So from leptospira, we move on to the rickettsial diseases. Though there are a number of rickettsial diseases and organisms with different vectors around that we see, the one which is of relevance to our part of the world is the scrub typhus. This is what I'm going to discuss. In the Western world, we can have Rocky Mountain spotted fever also, and even the other type of typhus like the epidemic or the endemic or murine typhus, which can be seen there. But in our part of the world, it is the scrub typhus which we usually see around. And Q fever is the only one in the rickettsial genera which can cause a chronic disease. It can be a cause of the seronegative endocarditis as well. Okay, so moving on to the clinical scenario for scrub typhus. So this is a patient, 40-year-old farmer from Assam. He comes with a 5-day history of high-grade fever, headache, myalgia, and lymphadenopathy, with a diffuse macular rash on the trunk, along with an ashcar on the lower leg. Now, the ashcar is the characteristic lesion which is seen on the site of the suspected bite of the mite. And the patient has history of exposure to bushy areas during monsoon season in the northeastern part of the country. On examination, he has fever, there is tachypnea, the blood pressure is fine, the saturation is normal, the patient is alert, mildly dehydrated, there's generalized lymphadenopathy, diffuse macular rash, and ashcar on the legs. though there is no respiratory involvement, hepatosplenomegaly, or neurological signs. The investigations would classically reveal normal hemoglobin, mild leukocytosis would be there, thrombocytopenia would be there, the SGOT-PT are usually elevated. And for the diagnosis of scrub typhus, the test that we do, serological test, is immunofluorescent assays or the ELISA, which are positive for the causative organism Orientia shushugamoshi. So IgM can be tested for that, or we can do a PCR from the ASHCAR. So swab for PCR can be sent from the ASHCAR. Supportive evidence can be availed from the test like Wheelflix, though they are outdated nowadays. Chest X-ray was normal in this patient, and mild renal involvement in the form of mild, the creatinine was 1.1, though it was normal, but kidney involvement can sometimes be seen. So the diagnosis of acute scrub typhus was made in this patient because of the presence of fever, rash, ASHCAR, lymphadenopathy, thrombocytopenia, a positive IFA and PCR, and a history of exposure in an endemic area. And the possible complications which we can have in these patients are ARDS, meningitis, and renal failure. So again, this is showing the chronology of the disease. So after the first week, there would be rise of the, after the first week, there would be rise of the antibodies which can be detected, the IgM and the IgG, using the immunofluorescence or the ELISA, or you can do PCR from early on in the disease course. So PCR is usually preferred, or otherwise you can do a serology test. Now treatment, the preferred drug of choice is again doxycycline, or the other drug of choice is azithromycin. Some people have tried combination of doxy and azithro in patients of severe scrub, though there was no clinically relevant difference in the endpoints with the use of combination. The only advantage was early defervescence, but no other real clinical outcome advantage was seen with combination of the drugs. So what is preferred is either doxycycline or azithromycin, if you cannot use doxycycline as in pregnant patients. So whenever you have such patients, you always have to monitor them daily for all the expected complications like ARDS, renal failure, meningitis via clinical assessment, CBCs, and kidney and renal function test. And if at all there is respiratory distress or neurological involvement or any signs of organ failure, you have to hospitalize the patient and you have to educate them. So in the initial stages, you might consider outpatient treatment, but if there is any signs of these complications, you have to admit them. So for the uncomplicated patients, the doxycycline is enough in the oral forms, but if it is complicated, then you might have to give the IV doxycyclines. Now, moving on to another case scenario of these zoonotic disorders. So this is a 28-year-old woman coming with fatigue, low-grade fever, and joint pain for past 5 days. She has recently returned from a camping trip in a wooded area. She reports removing a tick from her thigh about a week ago, and the examination reveals that she has fever and there's a rash, expanding red lesion with central clearing on the thigh. So the diagnosis for this patient is, yes, what is this rash? This rash is erythema migrans, and the diagnosis is Lyme's disease caused by Borrelia. So what is borreliosis? So in this, the infection is transmitted through a tick bite. The tick would inoculate the organism in the skin. After attaching to the skin for at least 24 to 48 hours, after inoculation of the bacteria into the skin, there would be a local lesion which is known as the erythema migrans. From there, the organism would go into the blood vessels, and the early phase will have some non-specific illness, migratory arthralgias, carditis, neuropathy, etc. And ultimately, there would be tissue dissemination and invasion, leading to involvement of multiple tissues like joints, CNS, PNS, skin, and others. So I will just discuss in details how Lyme's infection can affect various parts. So in Lyme's disease, we have various phases. You have a stage 1 of localized infection, you have a stage 2 of disseminated infection, and then you have a stage of persistent infection. So in localized infection, the infection is limited to the skin involvement. In skin, we have just discussed, there's a lesion known as erythema migrans, which develops at the site of the tick bite. During the first several days of the lesion has a homogeneous red appearance, and the center of the early lesion sometimes becomes intensely erythematous, indurated, vesicular, and necrotic. So in the center, there can be intense erythema, or sometimes even vesicles or necrosis can be seen in the center. And as the area of redness around the center expands, the most lesions continue to have bright red outer borders and partial central clearing. So with time, there would be an expansion of the borders with central clearing. Sometimes several red rings are found outside the initial one, so you can have some other lesions also around. So multiple erythema migrans lesions can also be there, and they are located at, they can be there anywhere, but the usual sites of bites are thigh, groin, axilla, etc. These are the most common sites of tick bites. And if it is on the head, this is important. So if it is on the head, half of the lesion would be on the head. So the only thing that you can see is a linear streak on the forehead. Rest of the lesions would be within the hairline. So when the erythema migrans is on the head, only a linear streak can be appreciated from which could be emerging from the hairline. And these lesions are usually hot to touch, and they can be having burning sensations. They can be itchy, they can be painful. So initial lesion is just erythema migrans. Next is the stage of disseminated infection. In stage of disseminated infection, you can have some general symptoms like lymphadenopathy, splenomegaly, sore throat, non-productive cough, and some arthralgias. But slowly, there would be some specific tissue involvement, which is most oftenly seen in these patients with the CNS or the PNS involvement. There could be fluctuating symptoms of meningitis with superimposed cranial nerve involvements. There could be peripheral radiculoneuropathies. And in Europe, the most common neurological system, which is manifestation, which is seen, is known as the Banwart syndrome, where you have neuritic pain with lymphocytic pleocytosis without any headache. So headache may not be there, but still in the CSF, there is lymphocytic pleocytosis. Some cranial nerves can be involved. On examination, neck stiffness is there only on extreme flexion. The Kernig's and Brudzinski's are classically, they may be absent, and facial nerve can be involved. So you can have some kind of meningeal involvement, cranial nerve involvement, but classical signs of meningitis may not be there. Other than neurological involvement, the other important organ system which can be involved in Lyme's disease is the cardiac involvement. And 5% of untreated patients will develop cardiac involvement, and the most common abnormality is the fluctuating degree of AV blocks, the first degree block, the Wenckebach, or the complete heart blocks. Sometimes the patient can have acute myopericarditis, they can have mild LV dysfunction, or rarely they can have cardiomegalies. The murmurs are usually not there, and the duration of cardiac involvement is usually brief. So within 6 weeks, the cardiac involvement would settle down. Another important place of dissemination is the musculoskeletal systems. They can be migratory musculoskeletal pains. The common sites of involvement are joints, tendons, bursa, muscle, bones, anything can be involved. So they can have things like osteomyelitis, myositis, peninsulitis, fasciitis can be there. Then eye involvement can be there, conjunctivitis, iritis, panophthalmitis, interstitial keratitis can be there. Another important skin lesion which you can see in Lyme's disease is the Borrelia lymphocytoma. It is a subcutaneous skin lesion typically seen on the ear or breast, and they are dense infiltrates of the B cells, which often form follicular structures, and sometimes they have even the germinal centers in them on histopathology. Borrelia lymphocytomas usually last for months, but they may even persist for years or longer. So this is important. This can be a delayed manifestation, Borrelia lymphocytoma. Then after the disseminated infection, then some patients would go in the stage of persistent infection. So months after the onset of the disease, within the context of a strong cellular and humoral response to the organism, the patient would develop intermittent attacks of joint swelling and pain, primarily in the large joints like knee. Okay, so joint pains, large joints of the lower limbs like knees can be involved. Sometimes even the small joints can get affected. And when you do the aspiration of the joints, there is inflammatory aspirate, 500 to more than 1 lakh cells can be there in the aspirate, mostly the polymorphs. A small percentage of patients will have persistent joint inflammation in the knee, and that can persist for several years. And for these patients with joint involvement, prolonged courses of the IV antibiotics would be required. And this is known as the post-infectious antibiotic refractory Lyme's arthritis. Another form of persistent infection could be involving the nerves. It could be diffuse axonal polyneuropathy affecting both proximal and the distal nerve segments. Sometimes patients can even develop chronic encephalomyelitis with spastic paralysis, ataxia, cognitive impairment, bladder dysfunction, cranial neuropathies, particularly of the 7th and the 8th nerve involvement can be seen. And in US, a late neurological manifestations of Lyme encephalopathy can also be seen in some patients with only subtle cognitive disturbances. So this is important that these infections can sometimes even lead to delayed or persistent manifestations involving the joints, the CNS system, the peripheral nerves, etc. Another important delayed manifestation of the persistent infection by Lyme's is the acrodermatitis chronica atrophicae. So this is a type of the skin involvement, and this begins as a red violaceous lesion which become atrophic or sclerotic later. These lesions, which may be the presenting manifestation of disease, may last for many years. And you can culture the organism from these lesions even after 10 years of the onset of the disease. So this is important. Again, a delayed complication. So this figure summarizes the features of the various stages of Lyme's disease: the early localized stage, the early disseminated stage, and the late chronic or persistent infection. So skin lesion of the early stage is the erythema migrans. In disseminated stage, you will develop several secondary annular lesions. In the chronic or persistent stage, you will have skin manifestation like the atrophic this acrodermatitis chronica atrophicae, or you can have Borrelia lymphocytoma. The musculoskeletal involvement can be seen in all stages of the disease, though in the early stage it is just limited to some myalgia and arthralgia. In patients of disseminated infection, it would be migratory joint involvement and swelling of the joints. And in patients with persistent disease, you can have prolonged arthritis attack and chronic arthritis, which is seen. Neurological involvement can be there in all stages. You can have headache in the initial stage, followed by meningitis and cranial nerve involvement in the second stage, followed by encephalopathy or polyneuropathy in the persistent stages. In a disseminated condition, you can also have the cardiac involvement. Constitutional symptoms like fatigue are majorly seen in all stages of the disease, and lymphadenopathy, generalized or regional, could be seen in the early stages of the infection. Some patients will also develop a post-Lyme syndrome or symptom, and this is again characterized by these non-specific malaise, fatigue, some minor joint involvements, and would require several months of antibiotics later on. So some can even develop these disabling joints and muscle pains for years. They could be sleep disorders, or there could be neurocognitive difficulties that we have just mentioned. For diagnosis, again, you can have direct methods like culture and PCR. So histopathology is usually limited. So it is either the culture or PCR which is preferred, and some stains, Warby Starry or the modified Detril silver stains help us in identifying these organisms. And others can be the indirect methods involving the serology. So antibody-based assays are the only type of diagnostic test which has been approved by the US FDA. And the CDC recommends a two-tier approach for diagnosis of this infection using the serologic testing. The first step uses a sensitive enzyme immunoassay or an indirect immunofluorescence assay. If negative, no further testing. But if there's borderline or positivity, then it is further confirmed by doing a separate Western blot of the IgM or the IgG. So this is again the summary of the two-step, two-tier diagnostic recommendation by CDC. So in the first test, just the immunofluorescence or the enzyme immunoassays. If positive, then confirmation by the Western blot. If it is negative, then you have to consider for the alternative diagnosis. Coming to the treatment of Lyme's borreliosis, it will depend upon the organ system involved. So if the disease is limited to the skin, erythema migrans, or the acrodermatitis, the choice of therapy is the oral therapy. The first is doxycycline if the patient is more than 9 years of age and is not pregnant. But if it is less than 9 years of age, then amoxicillin can be given. Even in other individuals where you cannot give amoxicillin can be given. The other choices can be cephalosporins like cefuroxime or erythromycin. In patients with joint disease, also similar approach. But if there is severe disease with involvement of the heart or the nervous system, then you have to give them IV therapy. The first choice being ceftriaxone, 2 grams per day, or you can have cefotaxime, or the third choice can be penicillin. The duration of therapy would also differ. In localized skin infection, just 2 weeks of therapy would be enough. In early disseminated, it would be 3 weeks of therapy which would be required. But in the persistent complications like the acrodermatitis or the arthritis, a prolonged duration of around 30 days, or in arthritis even 30 to 60 days may be required. In patients with neurological involvement, again, a prolonged treatment of 2 to 4 weeks is required. In cardiac involvement, again, you have to give at least 4 weeks of complete course with oral therapy when the patient is no longer in high degree AB block. So again, the same thing. So moving from Lyme's to another case scenario. So this is a 40-year-old male farmer presenting with a painless skin lesion on his neck. And he has history of handling animals and wolves a few days ago. The lesion started as a small itchy bump and then progressed to a vesicle and now appears like a black ulcer with surrounding swelling. He also has fever and malaise. So in this setting, the classical organism we should think of is the anthrax with exposure to wolves and the animals. So Bacillus anthracis is a large aerobic spore-forming gram-positive rod-shaped microorganism that is encapsulated and non-motile. The symptoms of the disease are usually non-specific muscle ache, pain, headache, fever, nausea, vomiting. The most common presentation is the cutaneous anthrax, which is caused by this, and it accounts for 95% of the cases. So most of the patients with anthrax will have the cutaneous form. And it is rarely fatal, and because the infection area is limited to skin, so it is you don't have any major organ system involvement. And treatment, and without treatment, 20% of these can but without treatment they can progress to toxemia and death in 20% of the individuals. The other forms of involvement can be inhalational pulmonary anthrax or the GI anthrax. Now these agents are important sources for bioterrorism. So in current times, we should be aware of all these diseases because of the high infectivity that they have. So small number of spores of anthrax, if you're exposed to, you can get these diseases. So these agents are potential sources of bioterrorism. Okay. So now in the inhaled form, again, the patient usually will have just mild fever and sore throat. But after some time, some of these patients will progress to, or all of them will progress to fever, dyspnea, stridor, hypoxia, and hypertension, which leads to death within 24 hours. And another form of involvement in anthrax could be the GI. This is usually from the ingestion of the inadequately cooked meat of the animals who have been suffering from anthrax. So patients can have the typical GI symptoms like fever, nausea, vomiting, loss of appetite, abdominal pain, bloody diarrhea, and sometimes would even develop rapidly developing ascites. So, and this is the rarest form, the GI. So most common is skin. Sometimes you can have the inhalational and rarely even GI. So diagnosis again would include the gram staining. You have to, from the infected skin source, you have to take the samples and send for gram staining. You can even do the PCR testing. And then depending on the system involved, you will have to do a CT scan or chest X-ray or the lumbar puncture, depending on the complications you expect. And in the GI patients, even the endoscopy may be required. For treatment part, the cutaneous or GI anthrax can be treated very well by the drugs like ciprofloxacin, penicillin, or doxycycline, and they're usually required only for 7 to 10 days. In patients with GI involvement, though the duration of therapy is not very well defined. So this is important. If the case is not associated with the bioterrorist attack involving the aerosolized anthrax, where the risk is high, Ciplox or doxycycline are recommended and should be given for at least 60 days. So in inhalational exposure, longer duration of treatment is required. So inhalational anthrax, 60 days of Ciplox or doxy, Otherwise, in cutaneous or GI, in cutaneous it is 7 to 10 days. In GI, it is not actually defined how long treatment is required. Another case scenario is a 34-year-old male farmer from a rural area presenting with fever for 3 weeks, with night sweats, fatigue, weakness, joint pain, lower back pain, loss of appetite, weight loss. He has contact with goats and cattle. He assists in animal births without gloves. He also has a history of drinking unpasteurized milk from the local farm. And he comes with fever. There's enlargement of this hepatosplenomegaly, mild enlargement, and tenderness over the lower back and knees. You can see there is some swelling, redness on the back and the knees. And investigations revealed anemia, low white leukopenia with elevated ESR and CRP. And this clinical setting, the classical diagnosis is that of brucellosis. Now, brucellosis is a disease which presents in patients with such an exposure to the animal, like we have just mentioned, assisting animal births without gloves, drinking unpasteurized milk. So there are 3 forms of illnesses which you can have with brucellosis. You can have a febrile illness which can resemble other tropical infections like typhoid or even malaria, etc. Sometimes patient can develop with a fever with acute monoarthritis, which is usually seen in the young child, and the joints involved are usually hip or knee. In the older individuals, they can present with long-lasting misery fever, low back pain or hip pain can be there. So this is again, there are various forms of brucellosis. The diagnosis is usually by the isolation of the brucella from the blood, CSF, bone marrow, or the joint fluid. This is the definitive diagnosis which can be made if you isolate the organism, or otherwise you can wait for the serologic testing involving the standard agglutination test. The treatment for brucellosis, the gold standard is considered IM streptomycin, 0.75 to 1 gram daily for 2 to 3 weeks, together with doxycycline 100 milligram BD for 6 weeks. Though the alternative regimen recommended by WHO includes rifampin 600 to 900 milligram per day with doxycycline 100 milligram twice a day for 6 weeks. So another case scenario, this is the most common one which we see very often, 28-year-old female from UP. She is a shop assistant, comes with 5 days history of sustained fever, abdominal pain, anorexia, fatigue, faint rose spots on the trunk. Symptoms include constipation, sometimes then followed by diarrhea, headache, weakness, no vomiting or bleeding, no comorbidities, no recent travel. There are some petechial lesions on the upper limbs and the lower limbs, maculopapular salmon spots on the chest and the abdomen. There is hepatosplenomegaly. And on investigations, there is almost normal. HP is fine, hematocrit is okay, WBC platelets are okay, but the blood culture is positive for Salmonella typhi, and a PCR is also positive for the S. typhi DNA. The Vidal is again positive, the typhi.IgM is negative. So this is something important. So when you suspect Salmonella infection or typhoid fever, the typhi.IgM may be negative. So we don't have to just rely on one test, typhi.IgM, for diagnosis of Salmonella. Rather, it is the blood culture or the PCR for the S. typhi DNA which we should look for. The LFTs were mildly deranged, the KFTs were normal, the ultrasound showed hepatosplenomegaly, no perforation or abscess. So this is a case of Salmonella infection or typhoid fever and managed by ceftriaxone 2 grams daily, because we have a high prevalence for the multi-drug resistant organisms. So IV ceftriaxone 2 grams daily is usually recommended. Alternatively, you can give them azithromycin. Fluoroquinolones are usually avoided because of the concerns of resistance. So during the first week of Salmonella infection, culture of the blood culture or the bone marrow cultures or the duodenal aspirate culture is what is to be done. In the second and the third week, it is the stool or the urine culture can be done, or the serology. Serology can also be looked for. And fourth week onwards, again, it is the stool or the urine culture. So the median magnitude of bacteremia is usually low. So sensitivity further decreases with low sample volume or antimicrobial use, which is often the case in our patients. So at least 10 to 20 ml cultures should be sent. So 10 to 20 ml blood culture should be sent if we want to make a diagnosis of enteric fever. Or for the serology, you have to have a 4-fold rise in the antibody titer in a paired sera 1 week apart so that you can make this diagnosis. So if the Vidal test shows TO and TH titers raised, then it is suggestive of Salmonella typhi infection. If it is TO and AH, it is paratyphi A. If it is TO and BH, it is paratyphi B. And only TO titers, if they are raised, it is just suggestive of recent infection. That can be seen in recent infection. But if it is only TH, AH, or BH, that means it is a previous infection or convalescence. So just Vidal positivity have to be taken in the right context. Now, another test that we have is the rapid antigen test, like the Typhi dot, which is based on the diagnosis of the antigen OMP. It has a sensitivity of around 84% and a specificity of around 79%. And some other rapid diagnostic tests like Tubex IgM can also be done, especially in the patients. It can also, not only typhi, it can also detect some paratyphi antigens. And again, it has a sensitivity of around 78% and specificity of 87%. Treatment of enteric fever. So ceftriaxone 1 to 2 grams IV BD for 14 days. So it is important 14 days. Cefixime, if you give orally, it is 20 milligram per kg BD for 14 days. So this is again important. Azithromycin 500 to 1000 milligram per oral OD for 7 days. And azithromycin again per oral if you have to give for the alternate treatment in patients with suspected ceftriaxone resistant isolates. You can give them azithromycin for 7 days or meropenem. Okay, another common zoonotic infection, high-grade fever, symmetrical polyarthralgia, erythematous maculopapular rash, which blanches. So this is what we commonly see with chikungunya, IgM positive. So dengue, chikungunya, all of them, Zika virus, all of them are common arboviral illnesses transported to us through the arthropod agents, and they're all types of these zoonotic infections. So after discussing all these infections with examples, how do you approach when a patient of fever comes to you? So you always have to take a proper history, consider the patient's risk factors, exposure histories, incubation, always do a complete head-to-toe examination. For history takings, there are several pointers which can help you point towards the diagnosis, like a step ladder pattern of the fever is seen in enteric fever. A tertian or quotidian fever can be seen in malaria. High spiking fevers can be seen in conditions like liver abscesses or enteric fever, malaria. Relapsing patterns can be seen in conditions like leptospirosis, brucellosis, or borreliosis. And saddleback fever can be seen in patients with dengue infection. So intermittent is when it comes to baseline in between. Remittent, it is when it does not touch the baseline ever. So with history taking also, you have to make an attempt to localize. So if there's GI involvement, you can think of enteric fever, dengue. If there's jaundice, you can think of viral hepatitis, leptospirosis, and typhoid. Respiratory symptoms can be seen in scrub, dengue, viral hemorrhagic fever, and even in lepto, as we discussed. That can be a presenting symptom, pulmonary hemorrhage, hemoptysis, cough, etc. Neurological symptoms can be seen in all of them: lepto, scrub, dengue, enteric. And then you can have the joint involvement, you can have cardiac involvement, you can have renal involvement and bleeding manifestations. So patient-specific factors have to be looked for: occupational histories, the recent travels, all these things, exposure to stagnant water or insect bite or contaminated water, all these things should be asked for. And also the exposure histories in the form of swimming, diving, hiking, mountaineering, poultry exposure should be asked for. Drug histories, the sexual contact should be asked for. The tropical fever should always be looked in context of the incubation periods. Conditions with short incubation periods include dengue, chikungunya, even the rickettsial infections. Medium incubation period, 10 to 21 days, can be seen in the conditions like enteric fever or leptospirosis or some viral infections. And long incubation periods can be seen in conditions like tuberculosis, leishmaniasis, and other viruses like HIV. And always do a detailed clinical examination relative bradycardia, hypotension, capillary refill, signs of dehydration, all these should be looked for. All these systems must be examined: respiratory, cardiovascular, GI, and CNS. Always look for various rashes, petechiae, chymosis, maculopapular rashes, Ashbur's, vesicles, etc. And last but not least, so as we have just seen, all these conditions, they are all important causes of acute undifferentiated fever in the tropical regions. The early symptoms are non-specific. They can lead to delay in diagnosis. Careful history has to be taken. Presence of rash, Ashker, jaundice, thrombocytopenia, organ dysfunctions should always raise a suspicion of these atypical infections. Doxycycline is usually the treatment of choice in all these patients whenever clinically suspected, because delay in treatment can lead to severe complications. So it is important that whenever we suspect, we give them empirical treatment with doxycycline, and public health measures should be in place to prevent these infections. So that would be all from my side. Thank you, everyone. I know in the interest of time, I cannot dwell upon the details of each of these infections. So I just made some examples there.
Well, thank you, Dr. Rupali, for a wonderful session and covering many diseases in the lecture and giving adequate time and an overview to each. So I think there are a couple of questions. If there are any questions, you can type in the chat. Most of the questions actually you have addressed, but there is one question: can leptospira persist chronically in humans?
Yes, sir, it can. It can persist in the urine for years, and it can lead to, yes, it can persist.
So Dr. Rupali had discussed that, touched upon that topic. Probably that is why it has prompted this question. So yes, you can have something like as Dr. Rupali says, you can have persistence of leptospira and manifestations for long. In fact, renal involvement, tubulointerstitial nephritis, all these things can be part and parcel. So they can stay in some parts of the body for a very, very long time.
Uveitis also, autoimmune uveitis is also there, which can
Right,
be there.
right, very right. So, other question, I think you have right. In spite of deranged electric drug of choices, doxycycline, so that you have touched upon. So, every rest is thanks only. So, if I have the permission of Dr. Ashutosh, so we will call it a day. Thank you, Dr. Rupali, for a wonderful session. Thank you to everybody who has attended and participated. Thanks once again. And we look forward to meeting again next time for the thyroid disorder and a fortnight after for another tropical disease session. Thank you so much.
Thank you, sir.
There is one question. Oh, I know this would have come. Your opinion of recent hantavirus infection contained in that cruise.
Sir, I think you would be a better person to answer this question.
So we were discussing it at the beginning of the session before the formal start of the session. So this hantavirus outbreaks keep on happening. So if you remember correctly, when COVID was about to end in about 2022, there was a hantavirus fever and outbreak in China again. So these are outbreaks which keep on happening, yes, and they have a very high mortality. So hantavirus renal syndrome is known to occur. It can result in hemorrhages also, and it can result in renal failure, acute kidney injury also. So these syndromes do occur definitely, and we need to be on the lookout. That is why probably Dr. Rupali during the end of the session has highlighted it that you should have a rational approach. So this is very, very important. And any atypical manifestation, you have to be on the lookout for new emerging diseases, because there are many diseases which can come with the advent of so global climate change, as well as with travel occurring every now and then, and diseases transmitting. So, well, thank you, Dr. Rupali. Thank you so much, Dr. Girish Mathur sir, Dr. Parekh sir, Dr. Narsimlu, and thanks to Ashutosh for carrying us through. Thank you. Look forward to having you again. Thank you. Bye-bye.